Hello, my name is Jeff Taylor, and we're here at the very end of the 2016 CROI in Boston. And I'm here today with to talk about HIV and cancer. And we're here with some researchers from the AIDS Malignancy Consortium, which is one of the NIH-funded AIDS cancer research programs. And I have with us today Dr. Susan Crown, who is with the AIDS the AMC, and Dr. Tim Wilkin from Weill Cornell in New York, and Dr. Margaret Borak from the University of Zimbabwe. So welcome, and thank you all for joining us today.
Thank you.
Thanks.
So what's happening in the world of HIV and cancer right now, and what was reported at the conference before we start talking about the AMC and what they're doing?
Well, I think that one of the more interesting papers was presented earlier today, which analyzed some of the results of the START study. And if you recall, that's a study that looked at different strategies for when to initiate antiretroviral therapy. And that was a study that was stopped early because it was clear that immediate rather than deferred initiation of antiretroviral therapy produced better outcomes. And the analysis that was presented today had to do with cancer endpoints, which were clearly far more common among the people who deferred the start of their ART versus those who started it immediately. And there was an interesting analysis of cancers that were infection-related versus those that are not known to be caused by infectious agents.
So what are some examples of those?
So, for example, the so-called AIDS-defining cancers are all infection-related. So Kaposi sarcoma is related to infection with a herpes virus known as HHVA or KSHV, and lymphomas are often associated with Epstein-Barr virus, and of course cervical cancers are associated with HPV. And one of the things that I found that was very interesting in this study is that the infection-related cancers were far more reduced by early initiation of ART than the non-infection-related ones. But the findings also suggested that maybe rather than classifying cancers as AIDS-defining versus non-AIDS-defining, that we should be thinking of them more in terms of infection-related versus not. So I think that may be a far more useful way of classifying these cancers in the future, and I think that's an important thing to come out of the study.
So for those who didn't have the luxury of starting early, do we need to be more vigilant with them in terms of screening for cancers?
Well, yes, but I think that it provides even more support for early initiation of ART in everybody who is HIV positive. It's a whole lot easier to prevent cancer than to treat it.
I do think that that's one reason why they're considering extending the START study for another few years to really see if this differential in cancer incidence holds, or whether now that everyone is on ART that the rates converge and are the same. I also thought it was interesting that the non-infection related cancers, it wasn't quite as spread, but 50% reduced cancers. And really, how commonly cancers were the endpoint. It surprised me a bit.
I thought one of the interesting things at this meeting is that a lot of the non-infectious complications of HIV or stress, such as cardiovascular disease, metabolic disease. But in fact, if you look at the START study, and if you look at the top two causes of non-AIDS related death, it's TB and cancer are almost equal. And this is particularly important in Africa, where both TB and cancer are very common. And so I think that there has been maybe not quite enough emphasis on cancer as an endpoint.
And this was a younger cohort, correct? It wasn't
36 was the
right.
median
Yeah.
age. Yeah.
relatively young for cancer.
Yeah.
But lymphomas, I guess, occur at that age, and I mean, it wasn't just Kaposi's, there was a lot of lymphomas as
Right.
well.
Right,
which
and
is
they were
very
almost
interesting.
equal
Yeah.
in frequency among the infection-associated cancers. Although, you know, having been treating KS myself for many years, I remember for years in the 80s and 90s, every time I would do a different study, the median age of my KS patients was always 37. So it's you know, I think that this is consistent with that.
Thank you for that. And anything else from the conference that you'd like to talk about, or should we delve into what the AMC is doing?
Well, we presented the results of ACG 5298, the phase 3 vaccine study, HPV vaccine study. And I'm just curious what Susan and others think. We did show that we were able to prevent oral HPV infections. It was a small number of events, but it looked very promising. So
Now, was this in both men and women, or both men and
then
women?
both men and women, but oral HPV and oral pharyngeal cancer is much more common in men than women, both HIV infected and uninfected. But overall, we didn't show, for people who've been highly exposed to HPV in the past, that there was really a benefit for vaccination to prevent anal infection with HPV.
Yeah, I mean, I think it's disappointing, but not entirely
No,
surprising.
I think that's fair.
I think the oral oropharyngeal cancer data is interesting, but that of course brings up another issue about oropharyngeal cancers, is that some of them are HPV related, and we might be able to affect that with things like vaccines, but others are not, and are probably more related to smoking and alcohol and other risk factors.
It definitely seemed like two distinct diseases just
Yeah.
sort of nearby.
Right.
Yeah.
So from our point of view, that's interesting, the HPV work, because we see a fair amount of squamous cell conjunctival cancer, which hasn't classically been one of the AIDS-defining cancers, but we think it is thought to be related to one of the HPV subtypes, maybe with sunshine and other factors. So that's an interesting area of work, but and there's very little work in that area in Africa, and hopefully the AMC will be taking that up a little bit
Right.
in the future.
There actually
That's,
is a study that is in the early planning stages to look at a treatment approach to squamous cell cancer of the conjunctiva in African individuals, and the study team is already looking at what kind of additional studies, including studies of HPV, can be done as part of the study, because even though people have tried, they've been unable to definitively implicate HPV in that tumor, although it makes absolute sense that it ought to be involved, but it's not clear that it is.
Well, certainly the research focus of the AMC has shifted to Africa as the incidence of cancers that's declined here, and it's such a huge problem. Do you want to expand more on what the AMC is doing in cancer in Africa and elsewhere in the world?
Sure. Well, we've had sites in Africa for the past 5 years, and after a slow start, I think we're making good progress. We've just completed the accrual of our first study of HIV-positive women with invasive cervical cancer, and Margaret's site in Zimbabwe was one of the major contributors to that study, and so that actually is our first fully accrued study, and we're hoping and expecting to use the results from that to design another study in women with cervical cancer to build on that experience. As I already mentioned, we're trying to develop a conjunctival cancer study, and we're just about to start our first lymphoma study in Africa, which will be looking at 2 different approaches to the problem of HIV-associated lymphomas. There's also an interest group that's being started to look at hepatocellular cancer in Africa. And of course, Margaret and I are both and Tim also involved in some joint studies, mostly in Africa, between the AMC and the ACTG in Kaposi sarcoma.
There's certainly a lot going on. Would you like to
Those
add?
data are 2, well, there aren't data to present at this sort of meeting, but they're big studies, the 2 Kaposi sarcoma studies, one on limited disease and one on aggressive or advanced Kaposi sarcoma. And I think we're slowly moving forward with accrual for both of those studies, increasing the number of sites in Africa that are actually enrolling to the studies.
Right, you're adding some more
which
this
is
year.
really good because it does things like build capacity for advanced research in cancers and other areas. So Kaposi sarcoma is going to be the start, hopefully, of the studies that Susan's talking about. I think the study on hepatocellular carcinoma is particularly interesting because of the infection-related issues. We don't think we see very much hepatitis C or IV drug use in Africa, but the data just aren't adequate. And we see a great deal of hepatitis B, of course. So I do think that's a really interesting area for research, actually.
Yeah, it's just that hepatomas and primary liver cancers require some diagnostic methods that aren't widely available, and so often people are diagnosed late in the course of their disease when it's very difficult to treat. But Margaret brings up a really important issue about building capacity to just deliver cancer therapy in Africa, and I think that's been really one of the very important features of these Kaposi sarcoma trials, that more people are developing a facility to safely administer chemotherapeutic agents, which is very important. But there's still lots of infrastructural issues to be dealt with in Africa, including a lack of radiation therapy facilities, which are quite important for a lot of cancers, and also the lack of trained oncologists.
Well, hopefully AMC can now push the needle in the right direction on
We're
this.
trying.
So Dr. Wilkin, I know you're a very active member of the HPV working group, and the AMC has a lot going on with that. Would you like to talk about some of their work?
Yes, I think one of the most exciting projects, we have a study that we're hoping to start in the next 6 months or so in Africa, really to try to improve our prevention of cervical cancer. So cervical cancer screening is difficult in many countries in Africa because reliance on a cytology-based method really requires a very good infrastructure, good collection techniques, great pathologists, great information, medical information to get the results back and forth. And really it's a big limitation to women being screened for countries that don't have that. So we're using a new approach, HPV test and treat. So there's a company that has a point-of-care high-risk HPV test, and we can actually use, within HPV, we can pick out the types that are the most at risk for causing cervical cancer, and we can invite those women to be in the study that have those types of HPV and offer same-day treatment with LEAP or cryotherapy to really prevent cervical cancer.
And LEAP is an excision.
Yes,
Yeah.
yes, the excision of the HPV infection in the pre-malignant lesions on the cervix. And what we're studying in this is actually whether adding on 9-valent HPV vaccine will improve the woman's long-term outcome. And that vaccine, which is not quite yet approved in Africa, but we hope it will be in the next 6 months or so, it protects against 7 types of HPV that cause 90% of cancers, HPV cancers worldwide. So it's really will be great to have the vaccine available. It's a big improvement over our current vaccines, and we hope that this will be a strategy that can be employed to really further reduce the risk of cancer.
Terrific. And then I know domestically, you're doing a number of studies as well.
Yeah.
Here in the US.
So the group is really very active in preventing anal cancer. And so we have study results from AMC 076 that we hope to present at the International AIDS Society in the spring, a nice positive result. And we're looking at topical therapies for anal precancers. But the big, huge study is the ANCHOR study. It's an amazing effort. We're hoping to enroll over 5,000 HIV-infected adults with anal HSIL or precancer of the anus and randomize them to either being treated with our best available treatments or being watched very closely over a number of years to show that screening and treating for HSIL actually prevents anal cancer. So that would give a high level of evidence to this approach so that it could be applied very broadly for HIV-infected people.
Yeah, I know that's a huge issue here, anal cancer prevention, because it's not always available. The providers aren't in place in many communities, and insurance isn't always won't always readily reimburse for the procedure. And I know it's a lot of people are coming down with cancer,
Yes.
and it's a huge
Yes.
concern in the community.
And that's been a big unmet need and a big focus for the AMC.
Well, you were speaking of capacity building, and certainly we're doing that with this study as well.
Yeah, that's a great point. There's capacity issues
Yeah.
all over, and so there have been a number of providers across the country that are being trained specifically, well, through this study, but really the benefits will go well beyond just ANCHOR, but for clinical care in these areas. So, additional providers in Atlanta, Chicago, New York, LA, a bunch of places across the country. So we are really expanding capacity.
Yeah. I guess eventually there'll be 15 sites, and we have a number open now and more to come.
Yes.
And I think the website is anchorstudy.org.
Yes.
People want to go online and click on their area of the country and see if a site is open or if it's going to be opening soon.
Yeah, and I think that there are links to the ANCHOR study on the AMC website. So if people are interested in other AMC studies, the AMC website is also there, and you can also link on ANCHOR.
Yeah. Just Google AIDS malignancy and
Right.
it will all come up. Terrific. Well, thank you for sharing that. Anything else you'd like to talk about before we all get on our planes and fly to our respective homes?
I think those are definitely the highlights.
Yeah.
Terrific.
Right.
Well, thank you again for joining us today.
Well, thanks for having us.
Thanks
Thanks.
very much.